My name is Dr. Rick Seguil.
And action. Hey, Jay had a... This is Kirk again.
And action. Hey everyone, it's Dr. Rick. And Hannah had a question about PCOS. PCOS is polycystic ovarian syndrome. Polycystic ovarian syndrome is usually when, well, I'll explain that in details in a second. But if this is the first time you're finding me, don't forget to hit the subscribe button down below and the alert bell to find out when I do new videos. So, polycystic ovarian syndrome. I did a little bit. I think it empowers people when you can see the physiology of what I know, but I don't want to get you too deep in the weeds. So, but you have to understand is to understand how this offset cycle affects you. So, this is a fallopian tube. This is your uterus, and let me get a little closer here. So this is your uterus here, and this is a fallopian tube. This is where the sperm comes in, the vagina. Sperm comes in here, meets the egg somewhere here in the tube, and you implant the baby. This is an ovary. That's where all the potential eggs are. So I have the progression of what happens this way, this way, this way, till either you have a baby or till you have a period. This is the timeline of hormones. So this here is something that you hopefully all know. Estrogen and progesterone, those are the dominant female hormones. And this is over the course of 28 days. That's the average cycle, right? This is the amount of hormones. So you have estrogen, progesterone, and a timeline of what happens over the course of 28 days. You also have something called FSH-LH. This is what triggers the stuff because it comes, there's stimulation that comes from the brain. Brain sends out information to the pituitary gland, and the pituitary gland decides to let these big hormones go, which control these big hormones, and that's your period. So, in a nutshell, let me just move over this way so it's easier. In a nutshell, we want to see, as you have your menstruation about the first of the month, we'll just call that day 0, day 1, you'll see estrogen and progesterone kind of build up over the course of 14 days. This is usually when the egg gets launched. If you're lucky and you're regular, at the 14th day you'll launch an egg, and then if it meets up with the right, if you're trying to have a baby, if it meets up with the sperm, then you have the egg get fertilized by the sperm. So, but what's more important, especially as we proceed onto learning about PCOS, is that in some cases, these guys, these big hormones that come from the pituitary, which kind of follow the peak of the estrogen here, they also kind of mimic the same thing. In fact, if we call this, these are the signals that come from the brain, the master controllers of the estrogen and progesterone, then you can tell exactly within a day or two when you're going to launch an egg. So that's with a normal woman, all right? So as you progress on from your menstruation, the end of your menstruation, which is 3 to 7 days, to launching of the egg, the first 14 days, you'll have something called the LH surge. That comes from your pituitary gland, and it slowly builds LH, that's luteinizing hormone. Two big hormones that I'll probably mention more in detail about my menopause video. Two big hormones, just essentially, we have some mild fluctuations, and there's a big thing called an LH surge. When you have a really fast rise in LH, luteinizing hormone, it also encourages the ovary to make estrogen. Estrogen, one of the dominant female hormones, because men have estrogen too, but one of the dominant female hormones. If it is peaked the same time when the LH surge occurs, you'll actually have the beginnings, as you see the ovaries here with potential follicles. That's potential. And then you have one dominant follicle that starts up and develops into almost ready to launch, and then launches. This is your ovary. There's a little guy that just left. That's an egg or an ovum. And as the egg leaves the ovary, the dominant one, usually it's one every month, you'll have it go down the tube of the fallopian or the uterus fallopian tube and then again it meets up and implants the baby. So as you can see, as we go through the timeline of the hormone, you'll see that it initiates a surge. The surge pushes estrogen to its level, and because of the high peak and then the drop, the egg launches. It gives us a chance for pregnancy. And then comes the second half. So this is the follicular phase. This is the secretory phase. Second half is responsible for if you implant, and if you do get pregnant, you have to develop the uterus. Going back here, you have to develop the uterus so it's ready to accept this new egg. So that's why when you have the remnants of the house of where the egg left the ovary, that's called the corpus luteum. Corpus luteum secretes progesterone, the second biggest hormone for women. Again, men have that too. In fact, I use progesterone cream at night to help with sleep, hot flashes. Unfortunately, I get hot flashes myself. So we all go through it, whether it's menopause or andropause. But progesterone is the most important hormone in the second half, from day 14 to day 28. So when progesterone is made by the corpus luteum, this little hole, or the old house of the egg, if there is no implantation, meaning the egg never met up with a sperm, then usually this egg atrophies, it disintegrates, and then the house, the corpus luteum, which is responsible for progesterone to prepare the bed for the egg, the corpus luteum stops secreting progesterone, it drops, and then you have the beginning of your menstruation. And that's pretty much it. That's it as far as what happens. And it's supposed to happen beautifully, sometimes it doesn't. And we're going to talk about this guy right here. So now we're going to talk about polycystic ovarian syndrome. So polycystic ovarian syndrome is when this little egg gets a little bit too stimulated by the LH. So here is my illustration. Hopefully you can make this out, but I know it looks kind of busy, but I thought I would interpret this for you. So remember, this is the egg that came from the ovary, right? You can see the colors. What a great matchup. So in this individual egg, the one that takes off, starts to develop, and is chosen because it has a lot of receptors in it for LH, FSH, this egg starts to develop really fast. So this is the pituitary gland. This is a little thing that hangs off of the brain. And the pituitary gland, when it's stimulated by gonadotropin releasing hormone, it makes the LH and FSH, two little hormones, remember? These two hormones here, and they peak. So the reason that they peak is LH, the specific one, LH, stimulates the outside of this little ovum to make androstenedione. That's androstenedione. Sounds like androgen. Androgen is male hormone, male dominant hormone. And women have it too, but it's important that you understand in this egg, when the outer shell, the theca, is stimulated by luteinizing hormone, it starts to make androstenedione. And when androstenedione is made at this outer shell, it diffuses into the inner shell, called the granulosa. And those cells are stimulated by FSH. That's pretty simple so far. And when the androstenedione from the outer shell meets up with FSH and an aromatase, or it's an enzyme, to the inner cell, it makes estradiol. So estradiol is the one, estrogen is the one everybody remembers or probably is familiar with as far as how the women's cycle is controlled. So if estrogen is made, then finally the little tiny ovum in the center starts to develop, and when it develops, one will develop, it will pop out and have its journey for hopefully finding a sperm, making a baby. So in the case where you, so for PCOS though, there's something that happens that's wrong I'll explain in a second. So in PCOS, the ovum gets stimulated by, this is the pituitary again, the LH is made from the pituitary when gonadotropin releasing hormone is released from the hypothalamus. It's the master controller of the brain. LH, for some reason, is made in huge amounts, and it stimulates the outer shell, the theca, but because it stimulates the outer shell in huge amounts, it makes way too much androstenedione. That means it makes a lot of male dominant hormone. androgen. And when you have androgen, say testosterone, and it's high in a woman, you're going to look like a 15-year-old boy that's maturing. So you're going to have little facial hairs, you're going to have sideburns, you're going to have facial hairs in the center of the body, you're going to have acne because of the excessive amounts of androstenedione. So when androstenedione is usually made by the theca, it, again, as I said, it usually gets to the granulosa, the inner cell, with the help of FSH to stimulate the ovum. In this case, you have way too much LH, not enough FSH, so the ratio is a little different. Normal ratio of LH to FSH, 1.5 to 1. Here it's 3 or more to 1. So I just had I think it was Hannah. Somebody came in, sorry Hannah, I don't remember if it was you or not, and the OB-GYN did an FSH-LH ratio and it was out of proportion. And I thought that should be enough. Now, you're supposed to have 2 criteria of 3. You're supposed to have ultrasound show cysts on the ovary, and that would be a whole bunch of these little guys, not just one, a whole bunch of them become positive. Say like this one. If this was a polycystic ovarian, you wouldn't have ovulation, you would have just a whole bunch of cysts. And that's painful. When they all enlarge at the same time, leads to a ton of pain. But in our case, it also leads to an increased amount of male dominant hormone. And you don't want that because you'll have the facial hair or the acne. You might even have hair loss and a couple other virilizing symptoms. But hirsutism is common, and when you have, that's why I'm talking about polycystic ovarian syndrome, because typically my patients have problems with lipids, that's cholesterol, weight, extra weight, insulin resistance, and then acne or facial hair. And it's very frustrating. It's morally degrading. So for some folks, some people are just breaking into it, some people have it terrible. And then it's very hard to lose weight. Which after, so the problem with too much androgen is that it also gives you all that in addition to making you insulin resistant. So the problem with, and there's a high association between polycystic ovarian syndrome and insulin resistance. It's when you have too much insulin and the body tries to block or ignore the insulin, and you just have to crank out more insulin. So you have too high of an insulin. When you have too high of an insulin, as you'll see in the Keto Practitioners, you're going to gain weight. And when you gain weight, you also stimulate this theca to make more androgen. So it's terrible. It's cycling downward. So the problem is that you make too much androgen, you have all the facial hair and the acne, you have the difficulty with weight gain, and it's a terrible system. So the theory is that there's something called a thrifty gene. Here's the treatment plan. So hopefully that makes it real easy to understand how you, I'm getting slapped by this thing, how you go from normal to polycystic ovarian syndrome. Irregular periods too, because if you don't have that, if you don't have the typical building up of a ovum, the launch and the release, just like this, if you don't have that typical progression, you're not going to have a launch of an egg, and you're also not going to have a period, because the menses is dependent on these up and down variations in hormone, and when there's no up and down variation, just one dominant, because of default, probably genetics, then you don't have the signaling to the uterus to have a period, so you don't have a menstruation. And when you don't have a menstruation, that lining thickens, and when it thickens, it can get to the point of endometrial hyperplasia, potential for endometrial cancer. So you can see why the downstream of this is very important. So there's something called a thrifty gene, and Pima Indians, the Inuit, a couple other populations or cultures from around the world have the, I guess at this point in the millennium, have the bad possibility of having a thrifty gene, where if you have times of starvation, the body takes as little calorie and fuel in as possible, but changes it to fat for hopefully storage during a starvation day. And when you have this, you have a propensity to keep fat. So when the theory is that thrifty gene sometimes makes way too much insulin, and when you get to have too much insulin, become insulin resistant. When you become insulin resistant, there's usually a stepwise approach to diabetes. So the other thing that also happens during that time is because insulin gets so stimulating to the outer theca and makes a lot of androgen, not only do you have diabetes, you also have the facial qualities of a man, you have the hair and the acne of a man, the irregular periods, and probably the moodiness too. So all this is not good, but theoretically it could be because the phenotype or genetic possibilities are high in certain cultures to have this kind of reaction. If you do have this kind of reaction, it's not bad, there's ways to control it. PCOS used to be called Stein-Leventhal syndrome. I don't know why they changed the nomenclature, but I think that it's easier to understand when you see polycystic ovarian syndrome as a diagnosis, because you just think, oh, okay, I must have a ton of cysts on my ovaries instead of I have Stein-Leventhal's disease, whoever that was. So, the ideas, when you have overproduction, maybe a genetic abnormality, the objective is for you guys, if it's just acne and facial hair you want to get rid of, there are blockers. Do I have it here? I don't have it here. Well, spironolactone is a medicine that's used to be used as a water pill in the 60s and 70s, but the water pill was found to block androgen secretion. So spironolactone, a mild water pill, if you use it once a day in the AM, it'll help block the conversion of a lot of androgen. So that might help. You just have to deal with the water part. If you take a water pill, you're going to pee. But at the right dose, you probably won't have that issue. So it would help, but it takes a while to manifest. So 3 months to 6 months, try and see what happens. You can also, because if it's more of the acne thing, you can always take topical acne medicines, which is fine. You're going to chase it though. It's better to get to the root of the root cause of the problem. But in some cases, antibiotics for acne, benzomycin for acne, pain in the butt, compliance is poor. But if you have somebody that's really young and having issues, you might not want to go with prescription medicines at first. There's a couple other, I guess we should talk about natural things to do. And since insulin increased is going to be a stimulus to drive androgen production, sometimes losing weight and getting to a really good body mass index and exercising would be helpful. If you exercise and that's easier said than done. I had somebody that commented, there's a lot of talk on diet, but nobody is doing anything with regards to just telling the people to stop eating. And if it was just that easy, we wouldn't have obesity. I'd be able to tell everybody come in, I want you to lose weight, get your BMI of 23, and I'll see you in a year. It doesn't happen because there's other things that get in the way. So it is hard to manifest, but if you can get driven to possibly lower your BMI, decrease your waist to hip ratio, decrease your waistline, decrease your dress size, that would help. Increasing muscle mass is important too, because when you increase muscle mass, you actually burn up more of the fat cells. You use the fat as fuel, and instead of having fat make a lot of insulin resistant issues, because the other thing that happens with down here is that when you make too much androstenedione, it goes out into the periphery, into your current existing fat, and it makes a weird estrogen called estrone. And that just screws everything up as far as the lining of the uterus, but that's not important right now. I think the concept is here, but the idea is that if you can burn up that fat, you'll have less of that insulin response, that insulin resistance, and easier control of your, at least a little bit of control over the amount of androgen. If you control the androgen, you control the facial hair. If you control the facial hair and androgen, you control the acne. So it does take time to respond to exercise, but if you're diligent with a long plan and a short plan, I think you can see it. It's sometimes very frustrating, especially when you have the thrifty gene. You try as best as you can, you're exercising an hour a day with cardio, 5 days a week, you're trimming down, you're eating better than anybody else in the office, and you're not losing weight. Well, that's probably because you have that phenotype. So you can't be frustrated, you have to keep on plugging away. There are some medicines that help with initiating weight loss. There's also dietary changes that help with initiating weight loss. Just have to hang in there. I usually say wait 3 to 6 months, especially through a Chicago 2-season time period. There's a lot of things that can occur during the time periods, holidays, barbecues, spring, fall. So just have to be diligent and have a long game plan. You can also have a short game plan about just getting through a fast or getting through an exercise routine for a body part, just breaking it in. See my video on how to begin weight loss. I'll put it down below. So the other thing you can also do are oral contraceptives. Oral contraceptives, they are hormones, and you can either get the prepackaged ones that are cheap or hormones that are compounded by a compounding pharmacy. I like Wholesome Health Pharmacy and Matt in Hoffman Estates, but you might have your own choice. It's up to you. But oral contraceptives would be one. If you can control when these things occur, if you can control the amount of estrogen, progesterone, that would be with your oral contraceptive, you'll actually displace this, and you won't have to, number one, you won't have a launch of an egg, but you'll also have the endometrium thinned, so it doesn't get to endometrial hyperplasia or potential for endometrial cancer down the line. You also have control of the amount of androgen you make because you're controlling the launch of the egg. If you control the launch of the egg with oral contraceptives, you control the amount of androgen. So hopefully that makes a little bit of sense. So the other things you can also, there are also other medicines you can use. Clomiphene, you might know about that, has infertility medicine, but it does help with also decreasing the stimulation to this guy. So we're using science to control this. And if you can control this, just like you would in taking birth control for preventing pregnancy until you're ready, I think that's reasonable because it controls all the other symptoms that you have when you have way too much androgen. So that in a nutshell is what happens with this. There are, so the fancy medicines, which I don't know what they cost, but I sometimes will give them, would be aromatase inhibitors, estrogen receptors, stimulators, and that will probably be as far as, I sometimes will refer off to a reproductive endocrinologist. Sometimes, well, not sometimes, they are the experts in hormone waves, and they have a lot of other options with regards to controlling symptoms. But again, if you can control the disease process with exercise, lifestyle, avoidance of inflammatory foods, maybe other foods and plastics that sometimes also stimulate a hormone receptor problem. Plastics mimic estrogen, and it screws up the cycle. If you have way too much estrogen lookalikes, you're going to screw up your cycle, and you'll potentially end up with an egg like this instead of an egg like that. In addition, certain foods, I think dairy is a problem. Unless you get grass-fed or free-ranged food, I think the antibiotics and the growth hormone that's given to our cows in the United States, maybe across the world, but I definitely think the United States, is controversial. It certainly could be conspiracy theory. I don't want to get into that. But if you can avoid dairy, I think that would be a good thing. If you have to have dairy because you love it and you're having cravings, please go to the high-end places like Fruitful Yield, Mariano's, Whole Foods, and try to get the dairy that's imported. I went to Italy in downtown Chicago, and they have a vast amount of cheese blocks from all over the world, and they'll put little flags as far as where they came from. So I just tested the cheese expert, and I said, hey, where's this from? What can you tell me about this cheese? And you start getting into describing the area where the cow was raised, the area where the cow grazes, the grass next to the river that's pure, no factories downstream or upstream, and a mountainside for the cow to look at. I'm thinking, wow, that's almost like the Kobe beef, where you're supposed to brush the cow, you feed the cow beer, you give the cow beauty, and it makes a better cow. I guess the better cow, you'll have a better taste of meat, and I assume that with a better cow, you'll also have better, healthier milk, if you want to go into milk. So that is important to maintain. If a doctor is on the fence, what I would do is a couple things. Number one, you have to take a gander. I have to take a gander of the hair distribution, the acne, the facial distribution on the body. I have to take measurements like BMI, waist-hip ratio, sometimes hard to do, or at least an establishment of waistline. And then there's a pelvic ultrasound that has to be done. That's the best. Sometimes when you have somebody that's a virgin or somebody that's older, which I usually have, you can probably get away with an abdominal ultrasound, but the accuracy for thickness of the endometrium, which is what you're looking for, is better with a pelvic. I've gotten away with a CT scan of the abdomen, but it's not the best for determining the size of the endometrium, the lining. It is good for looking for cysts in the ovaries. Ultrasound's the best. So you have to have a pelvic ultrasound to show this concept of a chain of pearls. they all enlarge. They're not just dots. They're like this big all around. And the ovary sometimes gets to the point of getting way too massive, and then it starts to secrete fluid and blood into the belly, and it's very painful, almost like endometriosis. So I also get insulin levels, 17-hydroxyprogesterone levels, DHEAS, thyroid profiles to lipids. So those are all important to make the diagnosis. Considering that PCOS is one of the most common causes for menstrual irregularity with women who have not reached menopause, I think it would be important to do this. Now, if your insurance doesn't cover it, then we're screwed. You have to pay a lot of money just to possibly help with a diagnosis. But I think a lot of women who are suffering with irregular periods, painful periods, acne, facial hair, obesity, difficulty with losing weight, mood changes, I think they do deserve, as patients, they deserve to have the full workup, including the evaluation of the ultrasound or the pelvis. So it is important to consider the best workup you can if you're going to be tackling this disease process. And then usually what happens is when you pass your first pregnancy, which you can get pregnant with a reproductive endocrinologist, they'll help you get pregnant, but anovulation, when you have a flat line LH and no launch of egg and just a whole bunch of eggs that didn't launch, you can still control that with science. And that's where I think medicine, Western medicine is important, because if you happen to have that thrifty gene issue in your phenotype, in your genes, you're going to be at a disadvantage to have this. Even if you don't want to get pregnant, it's still going into your 40s and 50s with excessive amounts of weight and difficulty with moving the needle when you try your hardest, very frustrating. And with frustration comes craving, poor sleep, and a couple other issues. So it's sometimes nice when you use science as a fast response. Maybe if you use medicines first, control the symptoms that hurt you or make you feel bad. Then you make the disease changes. So you change from a category of PCOS and obesity to PCOS and normal weight. Now, just because you're normal weight doesn't mean you're not going to have excessive amounts of androgen. You'll just have less of the theca stimulation from insulin. And that's one less problem, one less trigger. It'll still be easier to fathom. So I'd say medicines would be important if you can't do the lifestyle change. But if you do the medicines, you still have to work on lifestyle change. You got to chip away at that while you're on the medicines. Worst case scenario, you continue medicines until you're pregnant. Best case scenario, you continue medicines, make the lifestyle change, have that lifestyle change of healthy eating, exercise, proper sleep, stress reduction, decrease in certain things like tobacco and alcohol and dairy. Once you make all those changes, then maybe you pull off the medicines, and then you go ahead and have a normal period with less symptoms, and hopefully a baby, or you get to 50 or 60 without a hitch. Sometimes having a baby will reset all this stuff. Maybe that'll be good for you to get back into a normal period. Sometimes prolonged breastfeeding will also help you with those symptoms, but once you control the symptoms, then you can kind of go into the sunset. Then you have menopause to worry about, which I will talk about in the next video. I think the next video with menopause and menopausal symptoms always is based on having ideas about this cycle that happens, the menstrual cycle. And once you understand the menstrual cycle, you understand the disease process. Once you have the disease process, you're in control, and you can control the way this goes instead of just assuming that this is going to be life forever. You're going to have acne, new pimples, cystic acne occur every month, which is very frustrating. Or you're going to be out of commission and you'll need FMLA because you just are knocked into the ground when you have the development of the pain from all those cysts, the chain of pearls that occurs in the ovaries. So hopefully, Hannah, this gives you an idea about where I'm going with you. If you have any questions about the way you guys have taken care of PCOS with your doctors or your OB-GYNs or your primary care, please put them down below what worked best for you as far as herbals. Otherwise, I'll see you at the next Minute Clinic.